trim this at chair side, reduce the occlusion, cement it in the patient, and she'll leave with a tooth. We've taken about 5 minutes to adapt our margin to our analog and adjust the occlusion a little bit, so we're pretty close. Let me show you what it looks like. So here we have our analog that comes with a kit, and you can note that we've nicely adapted our gingival margin, and we've reduced the occlusal slightly. Let's see how it fits inside the mouth. So we've adjusted our occlusion, we've adapted our margins to the temporary. Now we just need to cement it and do a final occlusal adjustment. Our final step is to remove the excess cement from our margins and confirm our occlusion. The final check of our occlusion uses a thin mylar strip called shim stock, and we want to make sure we have solid contact on the adjacent teeth and can pull through on our temporary. Close down. Open. Close down. This was an ideal case to use minimally invasive surgery. By placing the implant without having to elevate a flap, we were able to take our impression, send it to the lab, have a very accurate gingival margin, and he'll be able to fabricate an outstanding permanent crown. Additionally, the patient's going to have almost no pain and swelling postoperatively. I know she'll like that. And probably won't have to have a whole lot of visits prior to cementation of the final crown. So all in all, a very, very good case for the minimally invasive surgical technique with immediate temporization. I like to try and take concepts that might be somewhat complex and deconstruct them, if you will, and present them to practitioners in such a way that they can see how simple things are. The classic example of that is dental implants. Really, you know, the concept of having to take a year course on dental implants is kind of obsolete now. With the implant systems that are available on the market, like the Zimmer system we'll be using here, the simplicity is there such that if you have a good understanding of the basic principles of implant dentistry, you can have great results without having to go through dental school a second time to learn how to do those procedures.
In this segment, Dr. Saligi will discuss the treatment plan for minimally invasive surgical implant placement and immediate temporization of a maxillary left first bicuspid.
We're going to demonstrate today a 57-year-old woman who's missing tooth number 12. On this case, we can clearly identify the osseous crest. We can also visualize the floor of the sinus dipping down into the area of tooth number 13 and 14. By positioning a periodontal probe in the area where you anticipate making your osteotomy, you can clearly see we have 12 millimeters of space available in a vertical position in which to place our implant. In assessing the interradicular distance, we find that we have approximately 7.5 millimeters of space between the two roots. It's important to also analyze the intercoronal relationship, which is approximately 6 millimeters. Sometimes you may need to coordinate with your restorative dentist reduction of any of the contours of the adjacent teeth or pre-existing coronal restorations. So in planning for this case, I know that I have ample room for a Zimmer tapered screw vent, 11.5 millimeters long, and a diameter of 3.7 millimeters. I like to use the study model to confirm the measurements that we see on the panoramic radiograph. If we place our periodontal probe in between the two teeth, we can see that we have approximately 6 millimeters of intercoronal distance. We can also appreciate that this area is slightly scalloped. And we can also measure our interocclusal distance. So our final examination will be the clinical examination, where we can determine the gingival biotype of the patient. If there is a very narrow zone of attached gingiva, it may be better to elevate a flap so that we can capture that keratinized tissue and end up with a more hygienic and cosmetic result. This next case will utilize the Zimmer tapered screw vent implant and the Hexlock contour abutment. The Hexlock contour abutment is specifically designed to mimic the natural architecture of the patient's alveolus. Additionally, because these contours and margins are built into the correct position, the general dentist will not have to prep the abutment at all prior to fabricating the final crown. Slowly close. Good. Close again. Open. So we've used the initial pilot, the 2.3 millimeter pilot, checked our positioning, and we're confirming our positioning now after drilling the 2.8 millimeter pilot. Close. All the way. Good. Open. Okay. So we've just placed a 3.7 by 11.5 millimeter tapered screw vent implant. You'll note on the fixture mount there is a flat side which corresponds to the flat side of the internal hex. It's important to have it oriented in this direction as the Hexlock contour abutments are designed for the lowest portion of the facial to align itself with this flat portion of the internal hex. Occasionally you may need to drive the implant slightly deeper. Conveniently, the same driver that attaches to the fixture mount also fits into the internal hex. So here we have approximately 3 millimeters of gingiva coronal to the end of our implant. So here we have the corresponding Hexlock abutment. This particular abutment that I selected has a cuff height of 1 millimeter on the facial and a flare to 4.5 millimeters, which should give us an ideal emergence profile for our final crown. Note, because of the well-defined shoulder and chamfer, the general dentist will not have to prep this abutment prior to fabrication of the final crown. So you can see we have adequate interocclusal distance for fabricating a provisional. So now we'll go ahead and take our final impression to send to the lab for fabrication of a crown at a later time. We begin our impression by placing the contour cap. The buff color indicates that it is a 4.5 millimeter flared impression cap. Here's our impression, and you can see we securely captured the relationship of the implant with our comfort snap cap. And then you can see we have perfect adaptation of the gingival margins. This will make it ideal for the lab technician to manufacture an aesthetic final crown. The Hexlock contour abutment is designed such that a provisional coping can go over the top. And on top of this, we can place an ion crown relined for gingival adaptation. So we have the contour coping already on the abutment. We're going to add a little bit of flowable composite to the inside of our ion crown. And cure it. We'll fill in just a little bit more with our flowable and then be ready to cement. All right, now that we have our margins adapted, I'm going to take this to the lab, adjust the occlusion a little bit, and we'll be right back to cement. We've done our final little occlusal adjustment. We're now going to cement the crown with temporary cement. Close down, please. Nice and hard. Open. Close. There, just like that. Hold it for me. Excellent. So we'll do a final little adjustment on the occlusion. Heavy occlusion on the premolar tooth and the molar, and just a slight bit of occlusion on this marginal ridge, but nothing that's going to disturb this implant. What used to be maybe a 15-appointment endeavor for a single tooth now is a 3-appointment endeavor. They see their general dentist who recommends an implant. They send the patient to me. I see the patient for placement of the implant and immediate temporization. They'll go back to their general dentist for routine cleanings. They'll check the quality of the tissue around the temporary, and we're ready for the final prosthesis. They go back and it's just cemented.
In this segment, Dr. Saligi will discuss the treatment plan for minimally invasive surgical implant placement and immediate temporization of a congenitally missing maxillary right lateral incisor.
Managing the congenitally missing lateral incisor is perhaps the most challenging implant case there is to do. Not only do you have concerns about root positions, but you have to maximize your emergence profile in an AP and a mesiodistal direction. Our final case today will show placing a Zimmer one-piece implant in the area of tooth number 7. This young man has had orthodontic treatment and is set up fairly well for the procedure. However, it is a slightly complicated procedure in that he had a deficient buccal plate, which has been grafted, and he has a peg lateral on the contralateral side. Looking at this patient's x-ray, we can see we have ample bone height. The floor of the nose is located right here. The maxillary sinus dips down right here, and we have more than ample bone in which to place the implant here. From a mesiodistal interradicular perspective, we have approximately 6 millimeters of bone. At the CEJ, we have approximately 8 millimeters of bone. Looking at our model, you can see the edentulous space here. We have built up our buccal ridge, so we have ample bone from a buccolingual direction, but you may see that this is a little bit of a challenge from a cosmetic point of view. I've discussed this case with the cosmetic dentist, and he plans on doing cosmetic bonding of the lateral incisor here once the implant and temporary have been placed over here. This patient is an 18-year-old young man who was congenitally missing tooth number 7. He was referred to me by his orthodontist, who's paralleled the roots, so we have an ample amount of interradicular space to place an implant. He was, however, a little bit shy on his labial bone, so he's received a small tunnel graft about 5 months ago to allow for ideal implant placement. So today, again, because we have ample space, and we'd like to get a temporary on as soon as possible, we're going to use a minimally invasive approach to this case. In other words, we will not be elevating a flap. We'll take time to sound very well so we know where the surrounding bone is, and then we'll place a tapered screw vent implant with a contour abutment to facilitate immediate fabrication of a temporary. The patient is scheduled to have either some bonding or a veneer placed on tooth number 10, and at that time, the general dentist will take an impression using a contour cap for tooth number 7. When we evaluate this edentulous space, we can note a few things. First of all, he has a slight amount of gingival hypertrophy on the mesial aspect of his central incisors. Additionally, we have a nice high area of bone and soft tissue on the distal of tooth number 8. And fairly high gingiva on the mesial of tooth number 6. Our implant will be placed in such a fashion as to try and generate a nice papilla and good gingival contour in this area here. Note we have a mucogingival margin very high, so we'll have no problem having adequate amount of attached gingiva around our implant. I'll be utilizing a hex-lock contour abutment to facilitate immediate temporization of this case. However, there's a good possibility that we'll be using a custom abutment for fabrication of his final crown so we can maximize his aesthetic zone appearance. Now I'm going to use the periodontal probe to carefully sound the area and make sure we have ample buccal bone. And I know that we have more than ample palatal bone by clinical examination. Also want to place my periodontal probe in the middle of his gingiva right over the crest to determine the thickness of gingiva. As you can see here, we have approximately 3 millimeters of gingival thickness, which means I'll need to add 3 millimeters to my depth gauge readings as I do my osteotomy. So that's utilizing our contoured pilot drill. The next drill we'll use is a 2.3 millimeter pilot drill. And you can see we've taken it to 16 millimeters, planning on placing a 13 millimeter tapered screw vent implant. With our guide pin in place, we can see we're evenly placed between the central and the cuspid, and we are aligned in a vertical direction as well. We'll reverse our guide pin and again confirm that we have the correct orientation. Now we'll move to our final 3.4, 2.8 drill. So we've completed our osteotomy. At this point in time, I like to use a periodontal probe to make sure we don't have any fenestrations in any of the walls of our osteotomy site. Then we'll place our 13 millimeter by 3.7 millimeter tapered screw vent implant. Bone all the way around. Excellent. Perfect. One of the things I found that aids insertion of the implant is to coat it with saline prior to placing it in the osteotomy site. This prevents it from binding and getting hung up, and also from overloading the fixture mount, effectively preventing it from jamming and making for easy removal. So we are placing the implant. Again, it's very important on these aesthetic cases to make sure that the collar of the implant is fully seated. So I like to remove the fixture mount and do the final amount of placement using the internal driver. Again, it's important to make sure the flat portion of the internal hex is facing the direct labial, which it is on this case. Now that we have the tapered screw vent implant completely seated, I'm going to go ahead and place the hex lock contour abutment and fabricate a temporary. Again, our impression will be taken at the same time as preparation of the contralateral lateral incisor. Now you'll note that our hex lock contour abutment is in place. Our gingival margin appears to be correct. And we need to check our interocclusal distance. We may need to reduce this prior to fabrication of the final crown. However, that will be able to be done in the laboratory with that information transferred back to us by the lab technician. At times when we fabricate immediate temporaries for anterior teeth, particularly the smaller ones like lateral incisors, there's not enough space to utilize the coping that comes with the impression kit. In cases like these, I simply reline an ion crown and adapt the margins directly. Once again, it's important to rough up the surface of the ion crowns prior to placing your flowable. That way you don't have to worry about them separating when you pull it off of the implant. So we have our flowable composite placed inside our iron crown, and we're going to slide it directly over our contour hex lock abutment and cure it from the top. I went ahead and adapted the margins with a little bit more flowable composite. Cut off the tab, we'll see how this fits, and we'll adjust the occlusion. So, in about 30 minutes we were able to place our implant. A tapered screw vent implant, 13 millimeters in length by 3.7 millimeters diameter, place a hex lock contour abutment, and fabricate a provisional. The patient will then see his cosmetic dentist for a veneer on tooth number 10 and a new temporary on tooth number 7. Once this is healed and we have the gingival contours we want, we'll take a fixture level impression and have a custom abutment manufactured and a permanent crown delivered. If we look back at implant dentistry, when it started, it was pretty much a surgically driven protocol. You may not have bone everywhere, so the surgeons would place the implants wherever they could. And then what happened is implant companies had to come up with a way to put teeth on these posts that could be directed in all kinds of different orientations. Well, where we've shifted now is that we have the ability to regenerate bone and soft tissue, and we can place the implants in more ideal locations. So 20 years ago, what may have been a success, when viewed now with an aesthetic eye, you can see these cases that may be cosmetic failures. So I think it's very important that you understand certain basic principles. Gingival biotypes, for instance, the condition of the adjacent teeth, what restorative options are available for the patient, because as a surgeon, you're doing a disservice to your restorative dentist if you can't add input into that planning phase, and most of all, if you can't deliver for the patient.